It's after 1 o'clock, so it's time to commence again. And Carmen is going to pick up where she left off and complete her presentation, and then we will proceed to take up the individuals on the afternoon agenda in no particular order. Carmen.
Thank you, Mr. Chair. I think before we had Senator Vickers and Representative Fettgetter, I was just about, I'm almost done, luckily. So there's not a whole lot left to talk about after the information you heard from Utah and Oklahoma. But real quickly, after caregivers that are allowed, typically 1 to 5 patients per caregiver, this is usually a spouse, an adult child, a parent if the person is under 18 or 21. And those are also limited. They can't be in there purchasing for themselves. You know, they have very strict rules and regulations about who they can purchase for and quantities. Roughly right now, about 25 states allow for home delivery, and some of those are normal times as well, but right now about 25 have been doing it because of COVID. 11 states do not allow for delivery, but again, some of them have been here and there allowing for delivery during COVID. IDs are required generally in every program, although in a couple they are optional through the Department of Health and Human Services, who is typically the ones monitoring those applications. And about half of the states recognize enrollees of medical programs in other states. Typically, their caveat is that they've either had to fill out a temporary access form that they may need to submit 2 weeks, 3 weeks before, have a nominal fee of $20 or something like that. And they're temporary for 30 days, 60 days, maybe up to 6 months. But those are also generally only allowed if the person is from a state that is very similar to that state. So it just depends, or if they have reciprocity agreement with a neighboring state, perhaps. So they could also be up to maybe a 6-month allowance on that temporary license. And then 19 states don't. So it's about half and half as far as letting folks in a program from another state. But they do have to buy the products from that home state, they can't bring it with them. That breaks both states' laws, but they can purchase from their visiting state. The next, I don't know if I get. Gotcha, thanks, Carlos. Next one would be, these are some of the broad differences in the programs for products that are available, access to the products, and purchasing. The packaging may be limited to X doses or X grams per package. It's generally in the form of edibles or a lozenge or a gummy, something like that. It would be 10 servings is typically the maximum, and or 10 milligrams of THC per serving. So depending on what that looks like, if it's like a bar of like chocolate that can be scored into 10 pieces, they are each have a little like indicia on them of a warning kind of symbol. It could be imprinted on it like a pill would be stamped, but they are labeled as containing THC. And they also will have a number of varieties of those products in a variety of strains, or what strains produce those products, which have ranges in THC and CBD properties. The access for medical use typically is 21. In some states, they do allow 18 to 20-year-olds go in and purchase at a medical dispensary themselves. But that is, again, they have a licensed card to do that. And they also can designate a caregiver just like anyone else can. And on all of the other states that have non-medical use, that's all for 21 and older. So I just want to make sure that was clear. The purchasing limits may be based on the type of product that it is. So there could be a purchasing maximum for edibles, for flower product, for concentrates or extracts. but it could be limited also just by the THC content. So someone could, they're allowed up to 200 grams of THC, and that might be just a little bit of concentrate or a lot of something else. And it can also be total weight of edible product. So, that if something's a heavier product, then it would be fewer of those items than a bunch of, say, small ones. And then local and state sales tax issues. Typically, it's just state and local sales taxes that are applied, if any, to a medical sale or some kind of nominal transaction fee. Excise taxes don't typically apply for medical purchases as they would in like a non-medical use or an adult use state. And that's how Representative Faggetter was saying Oklahoma has taxed it. So they are receiving income revenue from those sales above and beyond what the state is paying to enforce and regulate the system. So in summary, these are some of the state controls. These are the areas that the state level is usually setting, and that's the licensing fees and any of the owner and employee requirements. And I'm going to say a couple things about that in a little bit, but the testing requirements is another thing that's like a statewide requirement, whatever it's tested for, and the frequency in which it's tested or how much is tested of it. Packaging and labeling is also standardized typically across the state. And the localities may create things on the state will set general parameters of like they can operate these days from no earlier than 8 a.m. We'll just hypothetically say 8 a.m. to 10 p.m. But a locality may be able to come in and say, well, we want ours to be limited from 8 to 7 or something like that. So again, the state kind of creates the floor, but not the ceiling of the hours of operation. And the other things that are often controlled at the state level would be general requirements about advertising, or for like, are billboards even allowed in the state or not? Or if advertisements are allowed, what size they can be, signatures on buildings, things like that. Those are real basic things for that, can be at the state level, but those are really locally controlled issues because, as we know, locals will have different requirements, from city to city next door to each other. They could have completely different advertising outdoor rules. So, unless otherwise specified in their legislation or the initiative, the locals can regulate in another area as long as they're not excluded from doing that by the state measure. And they also generally, as I said, have the ability to opt in to the system and allow this kind of commerce or not, or only allow cultivation or only allow dispensaries, but not the other things. So it looks like a patchwork. And here are the areas, again, where the localities are more in control, the opt-in or out. And that could be on any level of the businesses, any local licensing fees, processing fees, requirements, or the types of establishments that are allowed. Local taxes are applied because then they can collect directly that revenue from the tax. They can gather that from the dispensaries for their own enforcement costs. And then again, the advertising permissions or restrictions. And then social use establishments, that's more of an issue in adult use states. But again, it's just an example of where states can decide whether or not, or localities can decide whether or not they can have delivery in their state or in their area. And then there are a few other areas, but those are definitely the major areas for localities. And here is just a side-by-side example of the previous two speakers we had, of really looking at some of those key differences in the two programs between Utah and Oklahoma. Utah, again, is the more narrow program that has about 17, depending on how you count, 17 conditions or symptoms that someone can have to qualify for their program. Referring providers, this was the best number I could find 628 registered doctors or osteopaths. It should be a PA for physician's assistant, advanced practice nurses. And it's basically anyone that's allowed to prescribe a Schedule II drug. And they have to pay a registration fee in order to do that. And it was $300 for 2 years. And again, Senator Vickers mentioned it's a limited number of patients, and that it used to be you had to be qualified and you could have the 200 or the 600 limit. But they, like he said, they just passed legislation this last session to open that up to have any provider do up to 15. The purchases in Utah, 1 month supply, they break it down by type of products. So the 1 month supply based on that recommendation from the pharmacist, 4 ounces, or it's lesser of these things, either a 1 month supply, 4 ounces of flour, or 20 grams of THC of flour, pills, liquids, patches, topicals, all the different categories. So it was the lesser of whatever that math is. Smoking is not allowed. And well, smoking is, they have flower product. I believe their language says they prefer vaporizing product compared to smoking it, which just means it's at a lower burn temperature. And they do not allow home grow. No sales tax in Utah are applied, like local or state. And business licenses in the entire state, 42 pharmacies as of March. And registered patients, he said they were around 30,000. My number showed on their website 23,000 as of March, as roughly 0.72% of their entire population of Utah. Chronic pain, because they include that as one of their conditions, is 40% of their card holders have indicated on their applications that that's why they're applying. Oklahoma, on the other hand, the qualifying conditions are at the doctor's discretion. Anything that somebody feels that the patient might benefit from, they can get the card. Referring providers, they have approximately, this is another area where it's optional for the doctors to register, but it's approximately 240 registered physicians, osteopaths, and podiatrists. And that was a new thing added this last year. But again, it's not required for them to register, but they can. And their purchase limits are 3 ounces of usable product, 1 ounces of concentrate, or 72 other ounces of other products. So because those could be your topicals, your tinctures, or patches. Smoking is allowed of their flower product, and they have that 6 plants of home grow total, and mature plants. And then they have the 7% gross receipts tax plus the sales tax, and that's collected all at the point of sale at the dispensary. And their business licenses, and this is on the state level, they have roughly 2,000 dispensaries in 2021, and their registered patients was 368,000 as of May. And that's 9.31% of their population. So that's kind of the key areas that the legislators were mentioning, and that's the result of having those types of regulations. So that concludes my prepared remarks. I do have some information based on some of the previous questions that were asked, which I'm happy to address at your discretion, or take new questions.
Go right ahead and address this question.
Okay. So some of the questions, Senator Vickers from Utah was right about this not being a one and done situation. You might enact something 1 year, but the next year you're going to have dozens of bills to make tweaks. And I mean, obviously that would be up to you all, but if you found things that you wanted to improve, change, add, those will happen from day one until forever. So do not think that these things are set in stone, because it's job security for me, which I really don't mind. So it's complicated. It's a complicated issue. So the policies are always going to evolve. For the Delta 8 issue that Senator Vickers brought up, states typically define marijuana, illegal marijuana, by their THC content. And so by people using hemp products that are lower than 3% THC, they can take that product and concentrate the THC that is in there, and that's largely the Delta 8 THC compound. So that's how people say they're maybe getting around the use or the intention of illegal marijuana, but they're still producing Delta 8 products because it doesn't contain the Delta 9. The residency requirements, they are often around 3 to 5 years to own a business or to be licensed in the industry. Or they will get like points on their application if they do have a certain percentage of people that have lived in the state for that period of time. Some states have changed those over time, so they might have started with a 5-year time limit or a 5-year requirement, but then they've typically rolled those back, largely because they see it as a way to get more people to come in with that experience, is that they were talking about from other states. And if they can come in and help improve, in their opinion, the system, then that's why they'll come into that state. Let's see, Senator Blackwell had questions about seed to sale and how the products are tracked. Products are tracked in every program through a seed to sale process. There are about, I believe, about 5 companies that work across the country with different types of systems that include like little barcodes for the plants. And they track literally the product that is taken from those plants and in those batches. They follow it along the entire process from cultivation to processing to that product going out into a manufacturer of edibles, concentrates, whatever that might be. So in the event that something down the road doesn't pass muster, so to speak, of maybe if it's an edible product, maybe their mold developed after 3 weeks, and they want to make sure that their customers know that, hey, check your product for mold. That package can be tracked back to literally the plant that it grew on. So then the state or the locality that does the testing might send out an alert to all the retailers to say, hey, if you have these products from this batch and this lot number, check your information, and then you can take that off your shelves. But it doesn't happen, I'd say, with great frequency, and at least being from Denver, I see what goes out on the Colorado level. It's maybe 1 a month, maybe 2 a month is what I've seen go out, but again, that can vary. Let's see here. As far as destruction of products after, if there is something that may have to take off their shelves, they have ways to dispose of it in store where they can like mix it with different compounds or chemicals to make it like not usable, or they have very large trash receptacles that are locked and very complicated to open. However, a bear in Lyons, Colorado has been known to try to walk off with a very large trash dispenser, and it was caught on camera. I can send you the link, it's really good. Let's see, THC limits in edibles, roughly, again, 100 milligrams per package or 10 servings. And the parent or the caregivers can be a parent or another trusted adult for that person. 18 to 20-year-olds in Colorado are now being limited as of legislation that passed 2 weeks ago. So those medical patients 18 to 20 can go into the dispensary and buy products now. Before, they weren't necessarily limited other than just the typical level of medical capacity sales. Now they're going to be limited by the amount of THC they can purchase in one buy, because there was fear and concern that that age range was going in and buying concentrate product and then going out and redistributing on the social market. And they're going to hopefully reduce the concerns of that through that measure. Law enforcement accessibility to these medical databases, they are very limited, and typically it's only going to be, is the person's name on a list or not? And it's not necessarily every officer has that ability to look that up, but it's somebody within the department that would be able to look that up. So they would have to call in and hope that the person that has that access is allowed to look at that list right now. And that's largely because of HIPAA rules with healthcare privacy information, and it's protected information because it's technically between a doctor and the patient. So limited access. Indoor versus outdoor grows, that is typically written into the state level information. Again, that could be controlled at the local level as long as it was allowed in the state measure. In areas where the climate could support that, outdoor could be an option. Indoor is generally preferred because they can force the 24-hour grow cycle on indoor grows and just grow a lot more, like the legislators were saying. They can stack it, X levels high, typically 3 or so, to maximize the space that they have indoors. And then as far as employer relations, I do have an extra slide on that, but local control or individual industry and company control is always allowed. So thanks. Every state allows private businesses to be private businesses. They can decide to test for it or not test for it. They're right about there being certain jobs that are protected for safety reasons, and that's obviously where the area of concern would typically be, but they can decide if they want to hire somebody or not, or even test somebody or not based on a drug screening. Nevada is one of the exceptions to that, and they require an employer to allow the person to use it or to be a patient, but they can't necessarily use it on site per se if it's going to cause harm to the business or another person at that business. So that's that's very rare. I think Nevada is the only one with that exact type of exception. And then Maine does not allow employers to discriminate solely for off-duty use, be that medical or adult in their case, but they are also not required to accommodate use. So especially if someone's under possession or under the influence at work. So they just that can't be the only reason in Maine. And then again, employers and industries with certain public safety or health concerns, or those that are receiving federal funding will often follow federal law to the T on this issue, which would mean drug-free workplace, 0 tolerance for THC. I think that is just about it. So is there any other questions?
Can you go back to the slide that's the comparison between Oklahoma and Utah?
Mhm.
I should have the population figures in front of me, but I don't. But Utah and Oklahoma are close enough in population to Mississippi that you can just, in the broadest of terms, talk about them. And in Utah, you have 42 dispensaries, pharmacies, whatever term you want to use, and about 1% of the population having a card to get access. In Oklahoma, you have about 2,000 dispensaries and 10% of the population having a card. So again, just in sort of broad general terms, think about there being 42 places in Mississippi where you could get marijuana, as opposed to there being 2,000 places in Mississippi where you could get marijuana. And you have just some, again, in the broadest of sense, idea of how many differences there are in what we're calling medical marijuana. And I keep insisting the first question that we have to decide as a legislature is what world do we want to have? And once we've decided that, the other issues sort of fall into place. As a technical matter, we are posting almost everything that anyone presents on the legislative website. And I'm guessing that it's possible to post all of these slides that you have on our website. And needless to say, I don't know how to do that, but someone else does. I forgot to mention when we were listening to the representative from Oklahoma, the district he represents includes a portion of Muskogee County, but it does not include Muskogee itself. I had planned to ask if in Muskogee leather boots were still in style for manly footwear, but I didn't get to that. Now, do we have questions before? Senator Blackman.
Thank you, Mr. Chairman. In your review of the state's legislation, in particular, those states that restrict the number of licenses and dispensaries, did you find did you find any of those states making some kind of consideration for small businesses?
Mr. Chair, yes, there are some states that do allow for that. They also do in some of the state adult use dispensaries as well, or systems as well. I believe Vermont is one, and I think Maine's another one. Sometimes they license them by tiers. So say they want a total canopy of X. They will divide that into what they might call like craft size, or, you know, small business size versus, so they might allow 50 of those licenses and then 10 of the next higher up above that. And there might be other things that could qualify them as a craft or a small business.
Okay, when you were also looking at those states that restricted licenses and dispensaries, did you find any that allow for Asian Americans, Native Americans, Black Americans, women-owned businesses?
Mr. Chair, yes, there are quite a few of those. That is one key difference typically between the programs that we're seeing coming online now, be they medical or adult use, compared to states like, you know, that had these established in the late 90s when this all started. So that is now more of an issue. Some states are finding it easier to set that up at the beginning of the process versus states that have already been with having their program, be it medical or adult use, for a while. It's harder to then go back and try to push them or get them into the industry that's already matured versus get them in an industry to begin with, you know, to have those reserved or qualified licenses from the get-go to get them playing on the same kind of even playing field from the start, instead of trying to get them in at the end when the market's already there. So sometimes they're limited, sometimes they're not. Sometimes it's a scoring process where they might get extra points for women-owned, different, you know, classes, ethnic classes, racial classes.
Okay, can you provide the chairman some of those states so that we could, if the state is so inclined to be progressive?
Mr. Chair, I'd be happy to.
Thank you.
Thank you, Mr. Chairman. You mentioned just a minute ago about the tiering of facilities, and you talked about canopy. I think the other way they do it is by plant count. Is that correct? Is there one method preferred over the other?
Mr. Chair, matter of preference would be up to the people in the industry. As far as the legislature and how they set that up, I have not necessarily seen a difference. It's probably, if I had to guess, I think it's pretty split. I don't think it weighs heavily one way or another, but I'd have to look into it for sure. I've been looking at those more on the adult use, just on the adult use grows or in the adult use states. So I could go back and look at some of the older medical states that currently do not have adult use.
Yeah, because those license fees are based upon either square footage of canopy or X number of plant growth. We've just briefly touched on this, but I just want from a national perspective, DUID laws. Could you talk about those?
So this is really the expertise of my colleague in our transportation program, but I know enough to just give you some highlights of that. States still have a variety of driving under the influence laws out there regarding cannabis. They can vary from if they believe you're intoxicated or impaired by THC by an officer's observations or smell, odor, however that might be. They can assume you are and take you in for a blood test. But the tricky part of that whole thing is that because THC can stay in your system for 30 days, some less, some more. And that also depends on how often you use and how much you use. So someone could be a medical patient who might use a couple times a day or once a day or on occasion. They may retain more in their system for a longer period of time than someone else. So the medical community out there in the scientific community, this is a very, people are very interested in this for obvious reasons, for public safety, but trying to find and develop a roadside test to determine impairment, which could be a judgment call as far as a behavior is concerned. A lot of states use 5 nanograms per milliliter of blood to say or to assume that person was impaired. But that is not an agreed upon standard in a medical community or that's just what started, and a few states have that specifically. Otherwise, it might just be positive or negative THC.
Right. So basically, it's really subjective to the officer behavior of the individual and stuff.
Mr. Chair, yes, that is often the case, as well as the increased use in polysubstance use. So people may be using both alcohol and cannabis at the same time. And at that point, if they're more likely to get a blood alcohol test on the side of the road than they are a THC test, because they can't on the side of the road. So,
Right.
you
And
know,
as
they
you
may,
said, you mentioned that I've read about the 5 nanograms, and
or yeah, nanograms.
the THC resides in the fat cells. So as you suggest, somebody could have used last week, but still show over that 5 limit and actually not be impaired at all. So not really a fair assessment of that individual's. All right. Lastly, and I don't know that we talked about this, how about opioid abuse? Any decrease across these states in terms of use and or deaths since they've had medical marijuana?
Mr. Chair, this is another very hot and interesting issue when it comes to research. Some groups and researchers have said that they have seen a decrease in opioid-related deaths, be they intentional or unintentional. But there are so many other things happening in those states at the same time. It's really hard to put any kind of correlation or most likely not even causation, but even a correlation between those two things. So, you have the increase in prescriptions of opioids out there that are going up, as well as the access to the marijuana at the same time. It's really hard to say when people have accidental overdoses or intentional overdoses and they have THC in their system. The scientific community is rather decided that you can't, so to speak, die from like an overdose of THC. You can have behaviors that might cause you to make a poor decision that would cause you to die, but it wouldn't be like an overdose in like an opioid situation. It does not like suppress your breathing. I'm not a medical doctor. I do not play one on TV. I'm just trying to describe what I've heard in my research on that, following, because states ask it all the time. And it's a valid question, of course. So some will say that there is a correlation to seeing a slow decrease, but other states will also see a slow decrease and they don't have a program, or they have a completely different looking program. Other times they're not seen to be related at all. But there's so many factors right now. I also cover opioid policy stuff. So there's just so many things happening in that issue with patients, providers, prescription drug monitoring programs. There's so many changes that it's hard to find what might be causing any increase or decrease on any of it. I wish I had a better answer.
Thank you. We appreciate your presentation and your being with us. David Roberts, are your doctors here? Well, if your doctors are here and they're ready, we'll hear from them now in whatever order they wish to present. If y'all would just come up and make yourselves at home and tell us who you are and what you want to share with us.
Thank you, Chairman Bryan and members of the committee. We appreciate being back here. I know you guys have had a long day and we've all had lunch, and so I'll try to keep my comments impactful but brief, but do appreciate always being here and being asked to speak. I'm Dr. Jennifer Bryan. I'm Chairman of the Board of Trustees of the Mississippi State Medical Association. I represent nearly 5,000 members, including physicians across the state of Mississippi, medical students and residents. I'm also a family physician in Flowood, and I have 3 children that I'm raising in Rankin County. By way of a brief background, the Mississippi State Medical Association strongly opposed Initiative 65. I know you guys are aware of that. And it's not because we as physicians lack compassion. I think our service during the pandemic has certainly shown our commitment to being compassionate and to doing the things that are best for public safety and for patients. So I just wanted to go on out and say that. We are compassionate folks. But it wasn't even that we didn't understand the issues surrounding the use of marijuana, but because we understood the cost of Initiative 65 to our patients, to the public, the Mississippi State Department of Health, and as we've heard here, had concerns about our workforce, the economy, criminal behavior, and such. This was not a decision of me alone, of our board, but of our membership. It was a very informed and overwhelming majority of our House of Delegates, again, representing the physicians statewide, after vigorous debate and careful review of 65 and 65A. Now, my long experience in the practice of medicine allows me to state with certainty that marijuana is not a medication. And I want to say that again. The physicians do not see marijuana, the raw product, as a medication. It is a substance to be studied. Medicine has a strict definition. It has a dose, a strength, a frequency, a route, and specific indication. And there's standard processes in approving medications, and our physicians are firm in stating that just because something makes someone feel better or alleviates some symptoms does not necessarily make it medication. In fact, I can think of several substances that people may use that we don't call medication that make them feel better. There are already FDA-approved cannabis products that have gone through our proper processes: Marinol, Syndros, and Epidiolex. I know of another one right now that's under research, some wonderful research being done into CBD, which you guys know is not controlled. So there's nothing blocking the research into CBD, and some amazing research coming through the normal processes and some really cool things that are forthcoming. As for medical uses of non-medical cannabis, there is limited evidence that cannabis may alleviate neuropathic pain in some patients. Insufficient evidence exists to demonstrate analgesic effects in patients with other types of chronic pain. So the State Medical Association would strongly urge that post-traumatic stress disorder, diagnoses like generalized anxiety, not be included as a qualifying medical condition for any marijuana program developed. And I refer to it as a marijuana program and not a medical marijuana program. And I think I've been pretty clear about why I call it that. As physicians, we believe strongly in evidence-based research and support research and strict guidelines to ensure public safety. Now, with the legislature now considering a medical marijuana program, it's important to note that physicians, our stance is to support our normal processes, our normal standardized processes. However, if you guys deem it to be appropriate for our state to move forward with a marijuana program of some kind, and we're naive, we're not naive, we understand the things that are at hand and are being talked about, we understand the pressures here. If you guys go forth with a marijuana program, then we would recommend that any program have a very, very narrow focus and take into consideration the following components as have been previously outlined to you by our state health officer, Dr. Thomas Dobbs. Firstly, it should be a medical program led by physicians and keep it as close to a traditional prescription as possible. So we would want upper limits on the dosing, just like medications. Preferably medical type formats that we're used to, like pills and liquids, or liquid inhalers, metered dose inhalers, not necessarily chocolate bars and brownies or joints that could be smoked. I personally took a big problem with that, smoking and combustion, because we took an oath to do no harm. And each patient that is inhaling smoke is directly harming themselves, and how any physician really could prescribe that is difficult for me to get my mind around. I certainly couldn't, but there may be some scenarios where there's a benefit risk thing that comes into that physician's judgment. We need to protect our vulnerable, our kids and our pregnant women, and allow strict limitations on the packaging. We've seen this with vaping, right? I mean, how they target kids specifically with the bright and colorful and fruity packaging and all of those things. That's going to be important. In any program the legislature considers, that we watch how this is marketed to the kids, advertising and packaging, to limit that appeal. And then, we're going to watch out for recreational use. We've heard today about what a problem that can be. And ultimately, I think that's where this is going. I think most of us see that, we're trying to keep guardrails on a program, but this is slippage, a slippery slope. And ultimately, I hope that if we do this as a state, we don't do like some of the things we've heard where we slip into a semi-recreational type situation. But why is that? I mean, are we just prudes and we don't want somebody to have a good time, or we are not sympathetic to someone's pain? Primarily this community mitigation. I'm concerned, I'm concerned about what's going to happen in our communities and with our business community, with the workforce. We need smart zoning. We need to fund mental health because the fallout is real, and we need to fund law enforcement. And any program that gets approved here, we heard about a standalone enforcement group there, and I thought that was a really neat way to mitigate, but there will be an impact, not just a positive one, and how we mitigate that's going to be really important. As far as dispensaries, just like we support physicians only, if the program comes to fruition, then we would support physicians only prescribing. We would also support pharmacist only dispensing. Have great concern for those who just went through to get a policy through a health policy type program to dispense the marijuana. I'm concerned about the guardrails. You think about, and it's not unlike COVID, really. We talked about a layered risk mitigation. It's not just vaccine. It's not just social distancing. It's not just wear your mask. If you put the highest level trained professional in both of those situations, a physician prescribing and you put a pharmacist dispensing, you've at least got some boards oversight. You've got a lot of ethical training. And I think that would be a safer model for you guys to keep in mind. Some of the statistics that are important regarding cannabis, and please forgive me if you probably are already aware, but I wanted to go back and say that from a physician perspective, the science is clear. From the National Academy of Sciences, cannabis dependence has a 9 to 10% lifetime risk. So a 1 in 10 chance of becoming dependent on the substance. 17% if they initiate as teenagers. A 20-year robust scientific program showed persistent and dependent users lost 6 IQ points. Now you talk about impact across our workforce and our communities, but non-users actually gained an IQ point. We see increased chronic bronchitis episodes, increased risk of car wrecks, decreased birth weight babies, which we already have a big problem with in Mississippi. 2 to 3 times higher risk, documented science of developing schizophrenia and psychoses. Here again, very important to fund mental health if the legislature authorizes a marijuana program. 6 times more likely to develop alcohol use disorder. 6 times more likely to develop tobacco dependence. We know the effects of tobacco and alcohol dependence. We've got a sick population already, so we need to get ready. 4.6 times more likely to abuse opioids. So we were just talking about opioid use a few minutes ago. Scientifically proven here. 4.6 times more likely to abuse opioids when people persistent and dependently use marijuana. There's increased cocaine and methamphetamine use, and 2 to 3 times the risk of depression. So finally, we believe that calling something medical that is not medicine really has kind of been a coordinated attempt to make this seem more benign than it is. So what we're here for as Medical Association, we've been clear how we as physicians feel about it, but again, understand there are other perspectives besides ours that you guys are taking into account, certainly, and we appreciate that. So we just wanted to give you some scientific thought behind kind of the fallout of what we would see in Mississippi and what we expect, because keep in mind, we're not Utah and we're not Oklahoma either. We've got some sick folks around here that we're already trying to get taken care of that are at risk. So we need to be forward thinking about what's going to happen. I personally think about our Medicaid program, the increased expense that's going to be there, taking care of a lot of chronic bronchitis and low birth weight babies, schizophrenia, depression, and so on. But that's for you guys to think about. I mean, the cost of Medicaid is a real concern. There's going to be a cost to private insurers as well. So I really feel like this is really, it's an industry, and I appreciate it for that. I think it probably will be lucrative in ways, and there's ups and downs, but it's really not medicine. It is a product that should be researched and is being researched, CBD particularly. And in closing, I'm going to turn over now to my colleague, Dr. Scott Hamilton. He is a wonderful physician. I know you guys have heard of him before. He is the medical director of the Mississippi Physicians Health Program. He's also the current president of our National Federation of Physician Health Programs. And he brings a unique perspective because he certainly understands. We've dealt with this with physicians who are impaired and substance abuse. And he is a state expert that I think you guys will appreciate hearing from. Again, so thankful to be here, and I understand the pressures and the demands and all, and appreciate the opportunity to speak for Mississippi's physicians. Thank you.
Dr. Bryan, could I ask just one
Yeah.
question? I think we're mentioning some statistics, and I'm not sure I understood what we were comparing. I think when you were saying that things are more likely, it's those who smoke marijuana are so many times more likely to have an adverse reaction of various types compared to those who do not smoke marijuana. Was that the?
Yes. So in a 20-year prospective study showed persistent and dependent users. So those who are using it and are dependent, we talked about there's a 10% risk for those who start using it, they're going to become dependent. So 1 out of 10 people, you can imagine, that take this up are going to need it and become dependent. Those people, those persistent and dependent users are the ones we're talking about.
So we were comparing, for lack of a better term, heavy marijuana users to those who are not heavy marijuana users.
I would define it as a spectrum you would expect to. It's not a flip. Yeah.
Sorry, is what?
It would be a spectrum you would expect. Yeah. So it wouldn't be a flip switch. You could expect that maybe if you didn't smoke quite as heavily, your risk would be less likely to develop those things, but still at increased risk.
Well, again, I'm not trying to be obtuse, but there's a group of people who are like 4 times more likely than some other group to have some sort of adverse outcome. And I'm just trying to get in my head what are the 2 groups we were comparing.
So there's one group that the study involved, and that is 10% of people who use marijuana become dependent on it. They need it. That's what we call dependence and addiction, right? Am I understanding the question correctly? And that's what this data refers to. So then you've got 90% of people who use it at some other varying capacity. And then you would hopefully extrapolate that data, you would expect across a spectrum as to those who used it more would have increased risk. Those who sparingly used it would have decreased risk. And that's anecdotally what we see in our practices.
We're posting on the website any written material you have. So if you've got any written material you'd like to leave with us, we'd be happy to post that on the legislative.
I'll be glad. Yeah, I can get that. This came from our health department and Dr. Dobbs' office. So I know we have all of that, and we can certainly provide it to you.
Thank you, Dr. Hamilton.
I really appreciate it. Thank you.
Thank you, Dr. Bryan, Chairman Bryan, and members of the committee. It's a delight to be here today. My name is Scott Hamilton, and I'm board certified in family medicine and addiction medicine. And in addition to the points that Dr. Bryan mentioned, which I agree with, I'll just focus on a few other points briefly, and then I'll be glad to answer questions. One thing I would urge is caution for use of medical marijuana in safety-sensitive workers. The acute impairing effects on complex reaction time and perception are well established. And so it's problematic for folks who are in safety-sensitive work because there's a lack of correlation between blood concentrations of THC and pharmacologic effects. And a previous speaker mentioned that the cutoff level for DUI in most states is around 5 nanograms per milliliter, but it's very difficult to predict impairment. So you don't know if someone's using acutely or not. If they are using acutely, we know pretty much unequivocally that it's going to have an effect on complex reaction time and perception. So a few comments about concentration of THC. The 3 cannabis-related drugs that we have now in the United States that are FDA approved all have THC concentrations in the range of 0.4 milligrams per kilogram per dose. And this is about 20 times less than average marijuana or the average concentration of THC in smokable marijuana. So the FDA approved medicines that we have now are much, much weaker than the concentration of THC in smokable marijuana. So we also know that the concentration of THC is directly correlates with adverse health effects. And there are many of these: possible psychosis, other health-related problems, as well as impairment. So I think having an upper limit of THC content is a very good idea, in my opinion. And a couple comments about opioid overdose mortality. We've all seen the ravages of the opioid crisis. I think last year we had the highest number of overdose deaths in our country's history and the greatest single year increase in 20 years. And so if you look at marketing of addictive substances in the last 100 years or 120 years, there's a similar playbook where any kind of problems are minimized, benefits are maximized, and the substance is used. And then over time, we figure out that they're not quite as safe as proposed, beginning with heroin, which was marketed at one time as a cure for morphine addiction. So we've seen this over and over. Marijuana is a little bit challenging because it is not FDA approved. So we got into the problems with the opioid crisis, and that was an FDA approved medication. One study that's quoted quite frequently by the industry is that there is an association with decreased opioid related overdose deaths in people who use marijuana. And that was based on a study published in JAMA back in 2014. And it was based on population level reports. A follow-up study to that was published in 2019 in the National Academy of Sciences determined that the association between medical cannabis laws and opioid overdose mortality has reversed over time. So any association with decreased mortality is spurious. And then I guess my last comments have to do with qualifying conditions. And I think this is really important to get this part of it right as an addictionologist. I think in general, terminal conditions are more acceptable for use of marijuana. So it's not FDA approved. So we don't know what dose milligram to use for any condition. We don't know side effects. We just don't know anything at this point. So to call it a medicine is a little bit premature. It certainly has effects when it's smoked, but so I would recommend extreme caution for use in any patient with a psychiatric illness, any patient, especially if they're a non-terminal patient. As far as the conditions that are listed in 65, one of those is PTSD, post-traumatic stress disorder. And that condition, even benzodiazepines are relatively contraindicated. So even in that situation, using benzodiazepines like Valium and Xanax should be done with a lot of caution. So using marijuana for that condition is a very bad idea and potentially dangerous. One other point related to use of opiates. One of the qualifying conditions is pain refractory to appropriate opioid management. Some folks would say that that's a little bit of a misnomer. It's really, really hard to use opiates appropriately for chronic conditions. We've been trying to do that for 30 years and we're at where we are today. And some conditions it may be appropriate. However, using medical marijuana in a patient who's already on maximum opioid therapy that's failing is very problematic. That population of folks that are on maximum opioid therapy who are not doing well, about 25% of those have a condition called opioid-induced hyperalgesia, which means that the opioids themselves are causing the problems. So you give them opiates, their pain gets worse. You give them more opiates and their pain keeps getting worse and worse. At that point, cessation of therapy is indicated. You don't keep giving them opiates. Opiates are the problem. So with this, what will happen if this is a qualifying condition is that many folks with opioid-induced hyperalgesia will continue on opioid therapy. And in addition, they'll end up on medical marijuana, which is going to even exacerbate the situation more because marijuana and other controlled substances actually exacerbate opioid-induced hyperalgesia. So those are the high points that I wanted to mention, and I really appreciate the opportunity to speak to you today. Thank you.
Dr. Brown and Dr. Hamilton, first of all, thank you for coming. Secondly, I think members may have questions that they would sort of like to direct to one of you or both of you. So if you don't mind, I'll just recognize people to ask questions and y'all can respond as you think best. Senator Wiggins.
Thank you, Mr. Chairman. I have two questions. And this, I guess, to both of y'all or how you would respond. So this debate or this discussion has been interesting in that I've had many constituents and others who support a program come to me and talk to me and mention the medical benefits of marijuana. And I tend to pose the question, okay, well, what does the doctor say? Or we haven't had the doctors come forward and say that they support it. And generally the response that I get is, well, the doctors, they don't know what they're talking about when it comes to marijuana. They don't know, the research is not there, or the research is actually there. They just haven't looked at it. And I only find this in this whole marijuana debate because I don't hear that when we're talking about, opioids or something like that. Generally it's I go to my doctor because they know about the health care of that. So can you explain what's going on or why this is happening? Why in this case, the people that end up talking to us are saying, I know better than the doctor. They just don't know about the marijuana.
Well, I can't get into other people's heads and speak for them. I can speculate that, you hear from people who are passionate. This has become very emotional. It's emotional for a lot of people. For us, we're scientists. It's data, it's studies. We know exactly what we're talking about when we speak as medical experts about it. I can understand that others may be emotional about it, and they also have things that they may be looking at or reference. But when it comes to the medical body of evidence, what we said here has been very clear, and there are a lot of things to be concerned about. And our message is, just to make sure that we're in touch with the medical experts and put guardrails on any program to make sure that we keep the public as safe as possible.
Mhm. Yeah.
Senator Wiggins, it's a great question. And I think really it has to do with FDA regulation.
Which
And-
that leads into my next question, but go ahead.
Yeah, the FDA's duty is to determine that a substance is safe and effective. So safety and efficacy. In medical marijuana, we don't know anything about it, frankly. And so we're kind of getting the cart before the horse. But since the cart is here, managing it medically seems to be the safest approach. So
Oh, go ahead.
Well, yeah, I mean, I know you guys have been studying this, but the Schedule I status has made it difficult to study. It's not that we don't know anything about it. We like to study anything. We want anything that's going to help the patients, right? But they've had that problem. But CBD is able to be researched and is being researched.
But that was my second question, was the scheduling, because my understanding is the way drugs are scheduled is based on their medicinal properties or the properties that they have. And so to this point, marijuana is a Schedule II, is that right? Schedule I, which Schedule I is that the highest? So it has the least, based on scheduling, it has the least medicinal benefits, if I understand that. And so then my question to that is, if 30 states have passed some kind of program, if 30 states have done this, why are we still having this debate about, or why has it not been descheduled or rescheduled or done whatever? And to your point, Dr. Brian, if that's the case, then that would allow y'all to study it. So we're having, admittedly, I guess on the federal level, that occurs with the FDA and all, and then states generally follow what the feds do. So we're sitting here waiting on the feds to do something. Do y'all understand my question?
Yeah, and even at lunch, I saw a headline, I admittedly did not read the entire article, where, the feds are looking at whether or not they need all of the strict laws that they have. We will study anything that will benefit patients, but the studying is important. And you've heard me on other battles up here, in particular, when we talk scope of practice, you can line up 30 states or 25 states, and I'm always the one that says what my mama and daddy taught me about jumping off the bridge, right? I mean, we still want to look at it as Mississippians and say, what's best for us?
But what did the schedule, it's a Schedule II,
Schedule I.
I'm sorry, Schedule I. So what does that mean?
We can't
the-
research it to the extent that we want to. It's a handcuffing of sorts.
And it's Schedule I because why?
Go ahead. Yeah.
So the schedules are based on abuse potential.
Abuse potential, okay.
Schedule I drugs are the most abusable substances.
So with that, most abusable, so we are talking about having a program which by federal guidelines has been ruled to be one of the most abusive substances.
Yes, sir, and there's more to it. It's also Schedule I, most abuse potential, and no legitimate medical benefit.
No legitimate, that's what I was trying to get at. So the debate is to provide a program that has high potential for abuse and no legitimate medical benefits based on the scheduling that goes on in this country.
Yes, and I'll speculate though that, marijuana, you can imagine all the derivatives from marijuana. I mean, that could be studied and in small amounts potentially, and we've seen have some medicinal benefit in these limited cases. But as it is right now, just to bypass the whole thing and call marijuana medicine, the scheduling, there are normal processes to go through that we're going around. It's difficult. It's a hard battle. I've heard that. I know it is. It's still our processes.
And that's why, just to conclude, that's why you're saying y'all would like to see a specific type of, I guess, marijuana or whatever, like you mentioned benzodiazepine, but there's a number of those. That's what you're saying, so that you can properly provide them.
Right, the cannabidiol is the other ingredient in marijuana that really has a lot of medicinal benefits. But so I think hopefully all of these states legalizing marijuana medicinally or for recreational use will pressure the federal government into rescheduling marijuana. Because right now it is very difficult to conduct a study on a Schedule I drug. Even cocaine it's Schedule I, but it also has Schedule II indication for nosebleeds. So
Because there's actually some medical benefit, right?
Yes. And there may be, my guess is hundreds and hundreds of potential medical benefits from different components of the cannabis marijuana plant. We just really don't know what they are yet. And once the scheduling is changed to facilitate really quality studies, I think the floodgates will open on even more uses.
I mean, it's an excellent point. It's one that we've talked about forever, that we'd like to see it studied. We'd like to see drugs developed from it. Marijuana is a plant. And it is not a drug, but it has multiple derivatives that could be studied, and the research is what it is. And you're right, there should be pressure to be able to study it. But where we are right now is we're just going to bypass all of that and have marijuana. And that's difficult for physicians to get behind and support.
Thank you.
Senator Blackman.
Thank you, Mr. Chairman. Dr. Hamilton, you are an addictionologist.
Yes, ma'am.
Do you treat a lot of patients with opioid addictions?
Primarily,
And they present themselves and tell you they are hooked on opioids?
yes.
Do you treat a lot of patients that, for marijuana addictions?
No, I don't.
Okay, thank you.
Anyone else? If not, thank you very much. And again, if you have any written material that you would like for us to post, we'd be happy to post that on the website, which is sort of what we're trying to do. Thank you for your time. I know you have busy schedules. We appreciate your coming to be with us.
Thank you for having us.
Thank you.
Senator Blackwell, would you want to introduce Ms. Smoot?
I think next up we have Amy Smoot. She's a patient advocate from DeSoto County. So Amy, welcome.
Okay, hi. My name is Amy Smoot, and first and foremost, I want to thank Chairman Bryan, Senator Blackwell, and the whole committee for inviting me to speak today. I'm a stay-at-home mom with 4 children. I spent 10 years of my life in emergency medicine. When I graduated EMT school, I took an oath to do no harm. I believe part of the reason I'm here today is because of that oath. Doing no harm means eliminating things which cause harm, stopping certain therapies when they have negative effects on patients, saying the right thing even when it's hard, trying everything even if you disagree with it, and lastly, not giving up until you have exhausted all options. Today, I was asked to speak as a patient advocate. What exactly is a patient advocate, and what do they do? A patient advocate is someone who helps the patient navigate the healthcare system. Advocacy means getting the prescription medication your patient can afford. Advocacy means making sure the patient is educated about their healthcare issues. It means making sure your patient is in control of their care. In today's capacity, I will be advocating for 3 specific children. All 3 children I will tell you about have horrific seizures. All 3 have failed multiple pharmaceutical drugs. All 3 have been harmed by conventional pharmaceutical treatment of their seizures. I'm asking you all to give these children a chance. Today, I'm requesting that you legalize their medication. I chose these 3 children because they are in my area. I will tell their stories, and I am demanding you to be compassionate and efficient legislators. I'm a volunteer. I'm tied to no specific organizations. I don't own a business, and I'm not a farmer. I stand here today as a mother. I am here because I have healthy children. These other mothers don't have any other options. They've exhausted all of them. When Initiative 65 was overturned, the rug was ripped out from their feet. The hope they had for their children and their futures were extinguished instantly. Medical cannabis can give these families hope. You can change it, and you alone. After all, these children are our future. The first story and patient I'm going to tell you about today is Riley's story. Riley is a radiant 9-year-old girl, but she's not your normal 9-year-old because Riley is going to change the world. At just 9 months of age, Riley was admitted for seizures at one of the top children's hospitals in the nation. During this hospitalization, a CT scan was done, and it was realized that Riley had half a brain. The very first hospital stay was traumatizing. Riley had to be stuck multiple times in every limb. She had to be held down by numerous staff members as she had not even reached 1 year of life yet. In fact, Riley's grandfathers were kicked out of the hospital because of their vocal opposition to watching their 9-month-old granddaughter go through pure agony. Unfortunately for Riley and her family, this is only the beginning of her story. When Riley was finally discharged from that hospital stay, she came home on so many medications. One of the medications was a gel shot to control her seizures. Her own mother had to administer the shots to Riley, and she sobbed every single time she gave one. That medication regimen went on for 6 months, twice a day. The side effects of this shot were horrible. At 9 months old, Riley was covered in rashes. She tripled in body size. She even stopped eating altogether because of this one medication. Keep in mind now, she's still seizing all the time. These medications weren't working. For 3.5 years, the seizures and hospitalizations continued. Medication after medication were tried, and not a single one worked to stop her seizures. Riley was put on adult doses of benzodiazepines as rescue medicines. She was 5 years old. Riley was hospitalized so much and so often that her parents began to lose hope. They were being forced to watch their daughter slip further and further away every day, and sometimes by the hour. Riley was so sedated, she became a shell of who she had been before the first seizure. She became catatonic, dazed, sleeping a lot, a long way from a normal 5-year-old's life. When she was 5 years old in August of 2017, she had her last hospital stay at the local children's hospital. She spent many days in the intensive care unit, and the adult dosages of benzodiazepines were not stopping her seizures. Adult dosages not stopping her seizures. After many days and no improvements, her neurologist dismissed her home to make preparations for Riley's death. There was nothing more they could do for her. She had maxed out on the medications she could have at a time. Any more and it would cause Riley to quit breathing. Riley was 5 years old. Her parents did take Riley home, but they did not prepare for their daughter to die. Instead, they packed up every single thing they owned, left their families behind, and moved to Colorado. At this point, they had no idea if medical cannabis would help their daughter, but they at least had to try. On their very first visit to the children's hospital, they knew they made the right decision. Riley and her family were now American medical refugees. Riley had her first dose of THC oil on October 5th of 2017. Riley had her last seizure on October 18th of 2017, 13 days after her first dose of THC oil. She has not had a seizure since. For 3 years and 8 months, her parents have watched as new life was brought to Riley. New life when they told her life was over and she would never get better. It took Riley months to wean off all the benzodiazepines. Riley had her last dose of FDA-approved medication for her seizures on February 15th, 2018. Riley takes THC oil 3 times a day. For the first time in her life, she is off all prescribed medications. The THC oil alone is enough to control her seizures. So why did I decide to tell Riley's story today? Because Riley and her family are from my congressional district. Her grandparents still live there today. But Riley can't come to her home state to visit her grandparents because her medication is illegal. Riley's story highlights the possibilities which become reality when we legalize medical cannabis. Riley was not going to get better, but now she's riding horses, participating in therapy, interacting with her siblings and parents. Riley is happy and building new strengths every single day. Riley is getting a new walker soon, which will give her much more independence than she has ever had. She will be able to move freely as she wishes. And Riley, most importantly, is teaching each and every one of us that a child who was counted out of life before the age of 5 can and absolutely will change the world. The second patient I'm going to tell you about today is Brian. Brian is a handsome 16-year-old baseball-loving boy. Brian had his first seizure at 13 months old. He was diagnosed with mitochondrial disease at age 3.5. There is no known cure or treatment for mitochondrial disease. Mainly, his family just tries to manage and alleviate some of his symptoms. But Brian doesn't need medical cannabis for his mitochondrial disease. He needs cannabis to stop his intractable seizures. Brian, at 16, has failed over a dozen pharmaceutical FDA-approved medications for his seizures. The majority of the anti-seizure pharmaceuticals have caused damage in ways that you cannot comprehend. Brian became so lethargic to the point he could not even sit up. Some caused excessive drooling. A few even caused Brian to have new types of seizures he'd never had before. Some caused severe, violent, and aggressive behaviors. Brian would be awake for multiple days in a row. We're not talking a little bit of sleep. He would not sleep at all during the day and night. All of those side effects, and he was still seizing. In addition to the seizures and medication side effects, Brian is still fighting mitochondrial disease. Some of the issues from mitochondrial disease are behavioral issues. Brian is a very hyperactive child, and he has a very short attention span. On top of all that, Brian has numerous food allergies. Cannabis certainly would not cure all of Brian's ailments, but it can and would absolutely ease some of his suffering. Reducing harm and providing a better quality of life for Brian is the least that we can do. The third and final patient I'm telling you about today is 2-year-old Miles. At first glance, Miles may seem like your average 2-year-old, fun-loving, adventurous, and full of laughter. But at almost 2 months old, he had his first seizure. He was taken to that same children's hospital as Riley, and his parents were told that he had reflux. 1 week later, when his mom put him in the pool, he turned blue, was stiff, shaking, and lifeless. The type of seizures that Miles have cause him to seize for hours at a time. Miles was just a fragile 2 months old when he seized for an excruciating 2 hours straight. Miles and family spent the next 12 months in and out of the hospital. Miles was still seizing all the time. Miles was airlifted over 20 times in several months. Each time he was intubated, and each time they would require loading doses of the FDA-approved prescriptions. The problem was these prescriptions were making the seizures worse. Each seizure, their answer was just to up Miles' dosage. They were sent to craniologists and epileptologists. All of them had another medication to add. None of them could give Miles' family any real help or answers. To this day, Miles is still mostly unchanged. They tried many things: high doses, low doses, leveled doses, and no changes for the positive. Miles has just gotten worse. Miles has failed 6 pharmaceutical drugs, and he is 2 years old. The rescue medication they gave Miles to stop his seizures never stopped him, not once. They had to prove to the insurance company that Miles' body was not absorbing the rescue medication before they would approve another medication for Miles. Miles has also been on narcotic intramuscular shots, which were showing some help at first. However, his body became resistant to the narcotic. Then the pandemic started. Miles was not able to go to the clinic to be seen as frequently. At 13 months old, Miles quit talking. He wasn't walking. He was very delayed. If you barely touched him, he got a bruise. When they were finally able to be seen, they had labs drawn. Miles already had liver damage. Now Miles' parents were left with an impossible task: to leave Miles on the narcotic, which was already not working, or to take Miles off all medication. Miles has stopped all FDA-approved medication. Remarkably, he started to walk again. He regained his personality, but he began seizing again all the time. Now that Initiative 65 has been tossed, Mississippi will lose this precious family too. Miles can't wait any longer. His parents are out of options. The physicians do not have anything else they can do for Miles unless his parents are willing to put him on more pharmaceuticals. I'm begging you today, please help Miles. I am terrified of what will happen to this 2-year-old radiant little boy. Senators, you all are Miles' last chance. Please do not let him down. And I also have a little slideshow he's going to play for me. You got to take it back to the beginning. There you go. going so fast. It says the whole 5 minutes is there, but it's going fast forward. Okay, well, I apologize. It's not. Oh. Okay, well, I apologize. I had a nice PowerPoint put together with slides with all the children and their faces and things like that. So I apologize. I will email that to all of you. I have your email address and that's mine. If you have any questions whatsoever, I'll be happy to answer them. I'll be happy to put you in touch with families if that's what you need. Just let me know.
Is it possible to play the video, or where does all of that stand? I thought there was some video.
Because it says 6 minutes, but it's not playing the 6 minutes, so I'm not sure what the. Okay, I'm sorry. I apologize. But like I said, I have your emails. I will happily email this to you guys so you can see it and look through it.
I'm sorry, all of this video Zoom stuff is so far beyond me. I have no idea. But,
Honestly, it's probably my fault too. I'm a PowerPoint newbie, so I'm sorry.
I don't know. I think it's my fault. The machines have been out to get me for years. The members of the committee have questions. Senator Polk.
Thank you, Mr. Chairman. Just a little clarification, Ms. Smoot.
Yes.
Riley went to Colorado.
Mhm.
Did I hear correctly that she went to a children's hospital in Colorado?
She went to Denver Children's Hospital out there.
And at the hospital, the doctors treated her with THC.
The doctors sent her, they have dispensaries up there. So the doctors basically gave her a recommendation, this much THC, how many milligrams, how often. Then she goes, their parents take that to the dispensary. They get an oil, which was one of the slides. She gets 0.3 of a cc of oil, and that's it 3 times a day. So she takes THC oil and it's concentrated, but it's just a little dose.
But the doctors recommended this.
Absolutely.
So to answer this question, it may be you, or if Dr. Bryan is still here, she may need to answer. Is the Colorado Medical Association an advocate of medical marijuana?
That is a question that I do not know the answer for specifically, but I will absolutely try to find that answer and get it to you.
Okay, thank you.
You're welcome. Once again, thank y'all for letting me come. I greatly appreciate it.
If you have time, I think there are a couple of other questions. Senator Blackman.
My question was the same as Senator Polk's, the dosage and how it was prescribed.
I'm sorry. Like I said, that was on the slideshow, but I will email it to you guys.
Senator Wiggins.
Real briefly, I think it was the first case you talked about that they couldn't get the THC oil, but it's my understanding that Epidiolex is allowed, which is a CBD oil, is allowed here in Mississippi. Am I right in that?
Some of it is, but the problem that you run into is that if you dose your child with it and then you take your child to an emergency room and that child then tests positive because of that tiny percent of THC, things get rolling like the Department of Human Services will come in, they will interview the parents because technically you're not allowed to give your child THC. It is against the law.
Well,
And
but that's a whole separate issue from if Epidiolex is allowed in Mississippi, which it is, and you're giving it for medicine, then you're not going to be, well, legally, you shouldn't be taken in by CPS and all that stuff.
Correct. And the answer for that for Riley, the specific child you were asking, CBD did not help her. And when they got out to Colorado, the doctors were able to figure out that THC, the type of seizures that she had, that CBD would not treat those type seizures.
Okay, so it was different in Colorado. It was different in Colorado.
Yes,
It was a different oil.
it's really concentrated oil, and it's made specifically for Riley. It's not something that just you walk in and buy. It's made just for her.
But their Epidiolex is allowed in Mississippi, which is a
Yes.
cannabis oil.
It's CBD. It doesn't have THC in it, as far as I understand.
But, all right. Okay, thank you.
Are there any more questions for Ms. Smoot? If not, thank you.
Thank you, Chairman Brian,
We
and thank
appreciate
you,
your
everyone
being
else.
here.
I appreciate it.
Dr. Brown, did you have? Okay. And our next presenter is Mark Cash. Senator McMahon, would you want to introduce him?
Mr. Chairman, thank you. Mark Cash is an entrepreneur and businessman in Lee County, Mississippi. He owns multiple businesses. One of his businesses is a CBD dispensary, and he had components within his business to also support a medical cannabis program based on the I-65, which we thought was going to be the law. And he's here today as my guest. With your permission, thank you. And I do want it to be noted that I'm good friends with Mark Cash, and I trust him as a confidant. He's given me a lot of good information, but I
So
am
we'll
I
be
am not a
sure-
client.
Won't hold it against him that he's good friends with you.
Yeah, I'm not a client, Senator Wiggins.
All right. Thank you, Senator Chad McMahon. Thank you, brother. Like he said, my name is Mark Cash from South Tilla, Mississippi. When Initiative 65 was passed, I began to open up CBD stores and with the intention of transitioning those into the medical marijuana program. I have one store in South Tilla, one in Starkville. When I started, I had a stereotype of what my customer base would be. As time progressed, that drastically changed. I've got nurses, I've had nurse practitioners, attorneys, business owners, just your everyday common blue collar worker that's come into our stores. They've all suffered with arthritis, neuropathy, anxiety, depression, PTSD. And I've seen the benefits of what our products have, which is just CBD with legal limits of THC. One customer that I have, Mr. Robert Timms Jr., he is a veteran. He has served in the Air Force, fought for his country. He was on the B-52 bombers. He's in stage 4 lung cancer currently. His wife has shared some things with me about the medications that the doctors had given him to go along with this. And she let me know that it impaired him to the point that he couldn't hardly function. It just knocked him out. She is buying the CBD flower that we offer now. With the legal limits of the THC set aside by the Farm Bill. And even though it doesn't take his pain away, it does give him a better quality of life. He's able to get up, go to the restroom on his own. He's been to my store a couple of times, and Superman. I mean, he's just amazing. The strength that this man holds. But if we could give him a higher level of THC to help alleviate even more of his pain and give him a better quality of life, he's terminal. he's not going to make it. If we could allow a higher level of THC to benefit him more and keep him comfortable, but still hold some quality of life in his last days, I think that'd be worth it. Another customer, he did not want me to indulge his name, but he said I could talk about his story. He suffers from dwarfism. He has underlying issues that go along with that dwarfism. He has about 10 to 12 seizures a day. The medications that he has been taking, he's still having 10 to 12 seizures a day on the medications that the doctors are giving him. So his mother actually came, and I think he's around 40, 45 years old. His mother's in her 60s. She came to my store. Now, I'm not a doctor and I'm not a pharmacist, so I can't prescribe anything, but she just wanted to try some of the CBD flower. She'd heard and done studies. So she came to our store, and she got the strain. Bubba Merlot is one of the strains that we carry in my store. She got that, took it back, and he's now down to 3, maybe 4 seizures a day. If we had a cannabis that had the higher levels of THC that might benefit the seizures, he could have a much better quality of life. His seizures are running, as far as recovery time, his seizures are running about 45 minutes recovery time. If you look at that, having 10 to 12 seizures a day, most of his day is consistent of having seizures and recovering from those seizures. He has no quality of life. But now he's down to 3 to 4 seizures a day, and his recovery time is diminished some, not excessive, but it has diminished some. The third customer that I have, she lost her son in a tragic accident. And the doctors had her on excessive prescription drugs for depression and anxiety, for just cause. I mean, who wouldn't? When she first came into my store, she and her husband came in, and she was there, but she was not there. It was just a shell of a woman. Her husband spoke. She never spoke. She was dazed off into the window, looking out the window, but never spoke to me. Her husband shared their story with me. She purchased some edibles from my store, and she came back, I would say, about a week and a half, 7 to 10 days, they came back. When they came back, I didn't even recognize her. She walked through the door came open. Hey, I'm back. I didn't even know who she was. I didn't recognize the woman. 2 totally different people. She had life back in her, she has now stopped taking, she told me she hasn't stopped taking everything, but she has to stop taking a lot of the medications that the doctors have given her. And she's doing the CBD gummies that we offer at the store. It's just amazing the benefits that you get from CBD, but if we had something just a little bit stronger, I think that we could benefit more. Like I said, I'm not a doctor. I'm not a pharmacist, but I'm just someone who can tell you the benefits that I've seen from customers that's come in our store. My father, I was his main caregiver the last 7 years of his life. He suffered from Parkinson's. He had 2 falls with it, broke both hips. He was on Marinol. Marinol failed him. Didn't do any good. A close friend of his managed to get him some marijuana. And I didn't oppose it because I'd done studies on it. My father smoked that. He could not even do daily functions. If we didn't give him something that he could actually physically stab with a fork to where it would stay there, he couldn't feed himself the last days. The last 2 years, actually. So when he started with the cannabis, smoking the cannabis, I took him to his doctor's appointment, and his doctor there in Saltillo looked at him, said, "Mr. Cash," said, "something's different about you. You don't shake him. You don't have a shake one." And the doctor said, "What's different?" I said, "Well, you want me to tell you the truth or you want me to lie to you?" He said, "I want the truth." And we told him what my dad had done. And he told us he wasn't opposed to it. He firmly believes in it. So that's the only thing I can bring to the table is just the benefits that I have seen from this. Some people may not say that cannabis is a medication. I differ. I differ a lot. I've seen it firsthand, and just the benefits are just tremendous that I've seen. Far from what I expected. I do appreciate your time. If you've got any questions.
Could you explain to us what you're selling and how it's legal for you to sell it?
Yes, sir. The flower that we have is the legal limit set aside by the Farm Bill. And then we've got gummies that are the same. The 0.3 THC that's in each product. We've got some that don't have any THC in it. We've got oils, we've got sunflowers right here. I brought with me. This is the lab results of one of our flowers that we have. And this is let me find it here. The Delta 9 THC. They've got it scheduled as LOQ on here. That means if it's undetectable, it's such small amounts, it's undetectable, they put LOQ on there. That's from the Denver area. Some others here. Let me see. Here's one that has 0.2, 0.08. If it's below that, it doesn't even register. So it's such small amounts of THC that the Farm Bill allowed us to sell.
But again, as I understand it, the Farm Bill that passed some time ago permitted cultivation of hemp, but it had very low levels of THC.
Yes.
And so that's the product that you're selling
Yes,
in
sir.
various forms. And so is it your idea that even that very low level of THC is having some benefit and that's the ingredient that's being helpful, or is it some other ingredient that is in the hemp that is having the effect, or do you know?
I don't know exactly. In my opinion, I think it's a combination of both. The CBD and the CBGs that's in marijuana, what I've studied are good for pain. Also, THC is good for pain. They're all good for anxiety, depression, number of things. One lady has fibromyalgia. She benefits from it that she comes in the store. But in my opinion, I think it's a combination of everything. But if those levels were higher, I think they could benefit more.
Senator McMahon.
Thank you, Mr. Chairman. I have a series of questions. So, Mr. Cash, I know the answer to some of these, but for the committee and for the sake of the record, I would like you to answer my questions. Were you born and raised in Mississippi?
Yes.
Yeah. The reason I wanted you to come and testify before the committee is I'm very sympathetic to what you're sharing and what Ms. Smoot shared as well about people that need it, but I'm more interested in the business side of it because I want to make sure that average Mississippians, everyday Mississippians that want to go into this business have access to the market and that they have fair and equal access to the market. So did you tell us about did you raise your own capital to open your own stores?
Yes, sir, I did. I did. Well, between the two stores that we have now, we've got approximately 100,000 invested in those two stores. I had a company prior to this.
You do not have to state the actual amounts if you don't want to, if you think it'll.
I'm not opposed to it. That's
okay.
fine. That's fine.
I'm trying to be helpful because I think Mississippians knew exactly what they were voting for when they voted for the I-65.
Exactly, we did.
I don't encourage anyone to use marijuana or any illegal drugs, but the people have spoken. The people voted. And part of the I-65 is everyday Mississippians wanted access to the market. They want the opportunity to go in business. They don't want high fees. They want it to be something that a guy like you, Mr. Cash, can enter this business. And so you went out, so you raised your own capital to go in the business.
Yes, I did.
Okay. And so what do you think is a fair fee? If we were going to have fees, what do you think is a fair fee for someone like you that's already gone through, you're already operational, you're selling CBD products, you positioned yourself so that you could sell medical cannabis. What do you think is a fair fee? You know, a lot of different fees have been thrown around, anywhere from
License, is that what you're referring to?
yes, a license, anywhere from $50 to $250,000. What do you think is fair as a business owner?
From what I've studied of other states, of the fees at other states, Oklahoma, I think, was a minimal fee that they had for businesses, which allowed thousands to come in. And like he said, there's one on every corner there. I don't think Mississippi needs that. We probably need, more than some that other states have. When you said, someone said about a limited number of dispensaries. Well, what about the people in the rural areas that can't get to those dispensaries if you're limited to 8, 10, 12 dispensaries across the state? What are they going to do? But I would say 25, 30,000.
Do you think that's a fair figure?
I do.
An annual fee? Is that an annual or a one-time fee?
Annual.
Okay. As far as the actual marijuana itself, the product, 5 ounces, the I-65, I believe, allowed for 5 ounces per person per month. I believe that was correct.
Right.
The state health officer, Dr. Dobbs, testified that would generate 5 ounces that an average person could roll 10 joints a day, 10 cigarette joints a day.
Right.
Do you agree with that, or do you think that's more? Do you think it's higher or lower? And I know you can roll it. I understand, like you can roll them thicker or something, but
Right.
in your opinion.
I deal in this every day out of our stores. We measure these out in amounts. 1/8 ounce of cannabis, you can get comparable to the normal cigarette that you buy at the stores. You can get 4 cigarettes out of 1/8 ounce. If you go with an ounce, I think Dr. Dobbs said 10 per day in a 14-day period, correct?
Yes.
Okay. By those calculations, that's 140 cigarettes in that 14-day period. In my opinion, well, no, not in my opinion, in facts, I do this every day. You can get 80 out of that. That was overshot by about 60.
Okay. Being a business owner, should we allow a segment in the law? Should we create a segment in the law to allow micro producers to grow or have plants? It's really 2 different questions. First of all, should we have micro producers? In other words, you may have mega producers that come in and put in these large facilities, but should we allow micro producers the way we allow for micro breweries in the state to compete against the large beer companies? Do you think that would be appropriate?
I do.
Do you think you would purchase from Mississippi-based micro companies?
Doubt. There's no doubt I would. I would much rather see everything, all our money staying in the state. Right now, all of our products come from Colorado, and it's from a company that's just CBD. If we had it here and harvested here, whether it's micro or whether it's larger farmers, I would definitely keep this money here in the state.
What about homegrown? What about, do you think that someone in Mississippi should be allowed a certain number of plants per person or per household?
I do.
You do? For their own personal consumption,
I do.
not for sale? I'm going to ask you one other question. If we're going to have a medical marijuana program in the state of Mississippi, I want it to be safe and regulated. You may or may not know the answer to this question. If you say you don't know, I'll accept that. But so if you were to go out and buy marijuana today, an ounce of marijuana in the black market, just go out and buy it somewhere in Mississippi, do you have any idea what 1 ounce would cost?
Around $250 to $300,
$300, $250 or $300?
depending on the grade.
So if you were a dispensary and you were selling medical cannabis, a safe product that had been tested, what do you think it would retail for in your store? Do you have any
I
idea?
honestly can't answer that because we haven't studied the full THC cannabis. All
Okay.
I've done is CBD.
And that's barring any taxation on it at all, with zero taxes. So
don't know
I
the
just wondered
market as
what you
far
thought.
as- I don't know the market as far as what that would cost us wholesale and then turn it around for retail. I've never researched that because we're not to that point yet.
I want to thank you for your testimony and thank you for answering my questions here before the committee and at home when I was curious about the product. There are multiple dispensaries already in Lee County that are positioning themselves to that we're going to support a medical marijuana or a medical cannabis. Is there anything else you'd like to share with me? Maybe something I didn't ask or?
No, Senator, that's pretty much it. I'm open to any other questions.
Thank you. Mr. Chairman, I yield. Thank you.
Senator Blackwell.
Thank you, Mr. Chairman. Just for clarification purposes, you currently get your CBD products out of state.
Yes, sir.
If we do a medical marijuana program, it's intrastate. It would be illegal if you got it from medical cannabis from Colorado or any other state, correct?
Yes.
All right. You mentioned a couple of times that you're not a doctor or not a pharmacist. But you think people would be better off if they had a higher dose of THC. So if we did have a medical cannabis program, somebody comes to your store, how are you going to recommend a higher dosage? What's your background to be able to do that?
Well, I can't do that. I'm not the doctor. The doctor should do that. That should be left up to the physician, in my opinion.
Whether
We can dispense that. Now, what we have, there is the Cannabis Training University that's studies basically training for stores such as myself. They have 9 levels of education, all the way up to a master's in cannabis. We are initiating that for everyone that works in our stores right now.
Great. And that's where I was going with this.
Yes, sir.
In a lot of cases or the states that I've been investigating, the physician does not recommend a particular dosage.
Right.
It's he certifies that the patient
Yes,
get it, they go, and somebody in the store then talks to them. In some cases, they have private room consultation rooms.
Right.
But it'd be you or your staff that would recommend higher dosages. And you would do so based upon having training.
Yes, sir.
Correct?
Exactly.
And
Absolutely.
as a businessman, you're not opposed to having that, going through that additional training cost for your staff, are you?
No, sir, we're going to require it.
All right, thank you.
Senator McMahon.
Mr. Chairman, I have another question. So, Mr. Cash, as far as those that could issue some type of certificate or a certificate of recommendation, medical doctors, you think they should be able to do a recommendation?
If they've analyze the patient, knows what their problems are. Yes,
What about nurse practitioners?
yes.
How about a dentist?
A dentist? I wouldn't think so.
How about a chiropractor?
Yes, absolutely.
Any other healthcare professional you could think of that should have the ability to write a recommendation?
Psychiatrist?
What about a licensed counselor?
In my opinion, no.
I just wanted your opinion. Thank you, Mr. Cash. Thank you, Mr. Chairman.
Thank you. We appreciate your coming.
Yes, sir. Thank you again.
Is there anyone here from the Department of Agriculture who wishes to? Dr. Dobbs, are you still here? Ken, that's what, I had asked you if you, I'd ask you if you'd be willing to sort of give us your impressions of the testimony during the day. So if you're willing to do that, just share with us what you think about what you've heard.
Thank you, Senator Bryan. Thank you to the committee. Senator Bryan assured me that nothing I say today will be held against me. So
Certainly not by me.
thank you. I'm the executive director of the Mississippi Medical Marijuana Association, which means I represent businesses who intend to get into the industry. But as most, if not all of you know from my previous testimony a little under a month ago, I was also the Initiative 65 campaign manager. And hearing from the doctors that spoke today, as well as from patient and business testimony this afternoon, I just want to reiterate something that is kind of a holdover from the campaign that rings in my mind. I understand that there are things that doctors can do to help patients, but the only reason why we're here is because 74% of Mississippians feel like that is not adequate. And I thank you all for what you're doing right now, trying to figure out how to come up with that inadequacy, because patients like what we heard of 3 children today, and the many patients that were described in Mr. Cash's business are really why we're all here from the vote that happened last year. So that being said, I'm sorry, I'm still a little choked up because I have a little 14-year-old boy and he's super healthy, but hearing about other 14-month-old boys having seizures was very, very difficult for me. So I'll get back to kind of what we've been talking about, or I've been talking about for the past month, which is more of what we talked about this morning of what kind of structure there is to the program. With Utah, you saw a lot of the kind of well-intended regulations that I think we're all considering right now about how to come up with a program. The supply chain side, the breakdown that the senator from Utah talked about was the thing we were trying to curb against with a free market nature of Initiative 65. However, on the flip side, you have Oklahoma where things were rampant, and thankfully the representative from Oklahoma said the free market has corrected itself. But I do think that strict regulations with reasonable fees and a strict adherence to a seed to sale tracking system with more oversight from law enforcement is the way you don't have to wait 3 years for the market to correct itself. It can start a little bit better. And then we saw from NCSL's presentation that a lot of the things that Initiative 65 had, 2.5 ounces every 14 days, that the private dispensary system is how a lot of other states regulate it. I think that's very important that we look at. Initiative 65 had a lot of elements that many other states have. And with that, I'll take as many questions as you like to ask.
Well, I'm gathering, and again, I'm just speaking in the most general of terms, that you think that the Utah system is overly regulated and overly prescriptive and has a lot of requirements that are not desirable. And so we have the fellow from Oklahoma, and I promise you I didn't put him up to saying this, but he more or less said we have something in Oklahoma that looks a lot like a recreational program. So is there any way to have a program which accomplishes the goals that you say you want to accomplish without having a program that quickly evolves into a de facto recreational use program?
Yes. So the stats from Utah are that there are roughly 0.46% of the population has a card. And as of the last time they looked at it, over 10% of Oklahoma has a card. All the different modelings for Mississippi based off of 65 had somewhere between 4 and 6% of Mississippi would eventually have a card. However, how do you curb against that becoming a recreational system? Obviously, I mentioned a seed-to-sale system mandated by 65. A lot of the educational requirements that Senator Blackwell was talking about, both on doctors or whoever is the certifier. I don't know if nurse practitioners and other certifiers would be included. But they certainly were earlier from the bill that was passed out of this body. But those extra requirements of continuing education credits, I think, are important, as well as extra education on dispensary or cannabis pharmacies. I don't know the nomenclature that we're going to have eventually, but the extra requirements on the employees that sit down with the patients to say, okay, what do you have? What has worked in the past? Here's with the knowledge we've learned about the application of cannabis. I think those are the things that you need to mandate that would curb it from becoming a de facto recreational program.
Well, as I understand it, under practically every situation, the doctor effectively gives you permission. And it seems that a lot of the decisions about what is dispensed and in what quantities is made by the dispenser, this individual and himself or herself. And that entity may be as important as a doorkeeper is the actual doctor.
I think it's important that that when we think about the program and the people who are involved in it, especially like you said, the people who are at the dispensary that are more involved in the dosage process because of the unique relationship between FDA approval, Schedule I, and prescription with doctors, that they can't interact with cannabis in the same way that they can other drugs. I think when you think about dispensary workers as part of the healthcare system and you start adding regulations and requirements on them, that's where you start bringing the whole thing more into a medical standpoint rather than the recreational program that would exist in other states.
Anyone have any questions? If not, thank you very much. We appreciate your coming. I will say this to those who presented today and have presented, and those of you who came to attend, thank you. We know that you all have other things you could be doing and other places you could be. The committee is struggling to try to find out what is the proper legislation to enact, and it is extremely beneficial to all of us to hear from all of you. So thank you very much for coming. Having said that, we'll stand adjourned.